Thank you, Krishnendu. Now we will invite Dr. Anna. She will be speaking on clinical applications of OCTA in AMD. And is
Hello.
Peter Haddon is there?
Sorry.
Yeah, please. You will be the next speaker.
Hello, thank you so much for having me here. It's my first AIOC in person. I've done a lot on webinars, but it's so nice to be in person here in India to talk to you about OCTA and AMD. I think the previous speakers already introduced OCTA. We know that, OCT has really transformed our clinical management all the way from the days of time domain all the way to swept source now. And you know that in AMD, we have it's not a new classification anymore, but instead of the fluorescein classification which was used to, we now classify AMD according to the histological layer of where it is in. So in the type 1 neovascularization, it's below the RPE, and as type 1 can also occur with PCV, and of course we have type 2, which is above the RPE, and of course type 3 or RAP that we were just discussing before. And I don't need to really introduce much about OCTA because I'm sure everybody in this room in the retinal subspecialty knows about it, but it really has transformed the way we do angiography, whereby now we do not need dye anymore, but we can still see the blood vessels. And here I just give you a overview of how I interpret OCTAs, especially if you're starting. This is a good overview on how you can look for the area of interest on OCTA, and because OCTA as a technology is only useful if you are able to be good at OCT and you are looking for the area of interest. Let's go into some of the AMD lesions. This is a type 1 neovascularization. As you can see in the multimodal imaging, you have an occult leakage picture on FFA and a plaque on ICGA. When you then look at the cross-sectional OCT, you see a multi-layered PED. And this is very indicative of a neovascularized PED. And when you do the cross-sectional OCTA, you see flow is indeed in the contents of the PED, and that flow translates into a membrane that you can see on fast OCTA. So what are some of the features of type 1 neovascularization? Already, as mentioned by the previous authors, there's some patterns that you can notice, the Medusa and the C-fan pattern, and that's especially important implications for response to treatment. You can see in this study where I did when I was in the US in New York, you can see that when we compare the different modalities of looking to see whether we could detect a type 1 neovascularization, with you combine OCTA and OCT, you got an 85.7% of detecting when you use this compared to traditional multimodal imaging with fluorescein and OCT. And really, OCTA also has limitations. So some of the limitations include when the PED is too high, or there's low signal strength, or sometimes in treatment-naive disease, you may not see the type 1 membrane as much. When you look at the comparison of OCTA versus ICGA, you can see that in ICGA, because of the leakage, its area is usually a bit larger than the OCTA image when you look at the OCTA and the vessels itself, because there's no leakage on OCTA. And the important thing, as we mentioned before, is OCTA allows neovascularization to be monitored in response to treatment. And you can see in this case, after 3 aflibercept injections, some things happen, and you can see the size and the density of the lesion decreases. In lesions that are chronic, you can see there's a prune tree appearance, and all the peripheral vessels, the small peripheral vessels and the anastomoses actually go away, leaving a more stable membrane. And this is important because a stable membrane, as mentioned before, actually leaks very little, and it helps prevent against atrophy, and we should be aiming for a stable membrane if you can't get rid of the membrane altogether. Type 1 and PCV is also importantly seen here. You can see a peak PED and a branching vascular network here. The peak PED is where the polypoidal lesion is, and the branching vascular network is next to it. And we know in OCTA that the cross-sectional OCTA helps us to find the polypoidal lesion. However, the on-fast OCTA can miss the polypoidal lesion in about 75%, and only in 25% you get to see the hyperflow lesion. However, the BVN is often seen quite well. And you can see in this case, we also have polypoidal lesions diagnosed on OCT and OCTA. And you can see that quite a lot of characteristics on OCTA can already tell you with quite a lot of certainty whether there's a PCV or not. Tomorrow, I will delve more in depth to it. At the same time, tomorrow, I will have another talk to really tell you a little bit more about how OCT and OCTA can help you not only diagnose PCV, but look at PCV response to treatment. I'll go on to the next case, and you can see in the type 2 neovascularization when there is a lesion above the RPE, and it's looked as on OCT as a subretinal hyperreflective material. You can see when you do OCTA, the flow is within the SREM, and then you can see a nice membrane over there. And you can see the flow is above the RPE, and there's again different patterns that you can see. And the dark halo around is actually a specific sign which is indicative of activity on OCTA. Again, response, you can see there's fragmentations of the peripheral vessels. They then form a very much more stable configuration and a prune tree appearance. And you can see even when they did OCTA at day 1 all the way to day 32, you can see the reason why we start needing to get injections at month 1 is because the lesion regresses but starts to reform by the time you get to day 32. And as rightly pointed out by previous speakers, you may be able to see recurrence of the vessels even before the leakage happens on OCT. And this is the same for type 3 neovascularizations. It's quite specific. And on type 3, the actual OCT on the cross-section OCTA is what helps you diagnose the type 3, because you can see this linear hyperreflective flow signal, and this is where the type 3 lesion is. And on fast, sometimes it can be missed because it's quite subtle. And you can see in response to anti-VEGF, we published a very early paper when OCT came out, and you can see the recurrence often happens even with the OCTA membrane growing even before it starts to leak after that.
You have 1 minute to go.
No problems, thank you. And you can see I mentioned before, these are features of an active CNV, and there are features of an inactive lesion. And the hypo area around it, as well as the branching tiny capillaries in the periphery, and the presence of the vessel termini, all are signs of active lesions. And 90.5 correspond that lesions that do not need treatment if you look at the prune tree appearance. And the quiescent CNV was also a topic of conversation, and you can see that we do detect them now before they leak, and if not, we do not still treat them as when they are quiescent. However, we should increase our follow-up period, reduce our follow-up period and monitor these lesions more closely, because the risk of leaking is much higher than those PEDs that are not vascularized. So I just want to finish up with some summary. This is a paper that we published anyways, and you can go read it because 7 minutes is no time to finish. But anyways, we know that OCTA allows the differentiation between flow and other hyperreflective structures. You can see that it can be used to classify PEDs as well as look at the different types of AMD. It is an easy, non-invasive method of imaging, and cross-sectional OCTA is useful for a screening tool. It provides information about flow and can help determine activity. And OCTA and structural OCT are comparable to angiography now to identify a lot of neovascular AMD. And quiescent CNVs can also be detected before active changes appear. With that, I want to invite you to APVRS in Singapore and our Fellows Advanced Surgery course. And I thank you so much for your time. And I am on time, I think.
Thank you.
Yeah, thank you very much, ma'am. It was indeed a very good presentation and very well presented.
Great.
Such a vast topic. Finishing in 7 minutes was a great task, and you have done it very well. And we would like to hear you again tomorrow.
Great.
Just one question. Actually, you have discussed everything in detail. Just one question. In SNEC, it's a big institute. What do you see in the trend in last 4-5 years? Has the dye angiography gone down drastically, or you're not doing it at all?
I think so. What I tell initially when OCT came on, on, we're a bit cautious. We still always wanted to back it up with fluorescein and ICG. But I think as the technology has gone, and now we've been using it for about 4 to 5 years, I think when it's really obvious and you see the neovascularization when you do the OCTA, then you can be confident you don't need to do a fluorescein because it's not going to tell you much more information. This is in typical AMD. For PCVs, however, because a lot of the polypoidal lesions can be missed, I think for PCVs, the ICGA is still important. However, when the lesion is not found on the OCTA, then I think you definitively cannot say it's not there, and I think you do need to back it up with angiography.
Thank you. Thank you very much.
No problem.